Hello, dear colleagues. How are you? Assalamu alaikum. Konnichiwa. Ni hao. Good morning. Bonjour. Guten Morgen. Now it's a guten Tag. Buongiorno. Здравствуйте. Саламат страна. It's a greeting in different languages. The last one is in Kazakh. We can say Salim, Salamat, or like in all Arabic countries also, we can say Assalamu alaikum. Assalamu alaikum. It's common to our country. Now we have a case of MCA aneurysm on the right side. Before, I will try to do it like this. This is a patient with multiple aneurysms. The aneurysm number 1 on the right side, MCA, and this is number 2, paraclinoid on the left side. This is a topic of the next treatment. And also patient has a aneurysm formation on the bifurcation of the left MCA. It's just the baby aneurysm, newborn, and this is aneurysm approximately 2 millimeter. And now I will show you the aneurysm on the right side. This aneurysm is approximately 4 millimeter neck, nearly 5 millimeter. The width of the dome 5 by 2.5. It's approximately like this. It's 5 by 2. And patient had a TIA. It was a clinical manifestation. That's why patients start the diagnostic process, and finally on the MR, this aneurysm on CT angiography were found. Now we are preparing with 5 cc syringe, 3 cc contrast, 2 cc saline. It's a 60%. 3 cc contrast, 2 cc saline, 60%. Just taking syringe like this, the septor 4 by 15 like this, it's a septor C. And now I'm inflating the balloon. We had several balloons for the last 2-3 years with a small hole. It's a damage from the manufacturer. And now you can see the balloon looks nice. I hope you can see. Yes, now we inflated the balloon. After the balloon inflation, we put the balloon inside the saline. It's very important during the deflation process. The tip of the balloon should be inside the water or contrast, because there is a small hole, and if you just take outside of the water and deflate the balloon, it may aspirate some air, and during the inflation, balloon could be non-properly prepared. Yesterday we did one of the last cases, and we tried to show the anchoring technique, and during the anchoring technique we inflated the balloon on the cervical ICA in the Petro segment. It's a proper preparation of the instrument. Most of the time I'm lazy. I'm trying to avoid additional steps. That's why I'm just preparing. I'm looking for the balloon. If the balloon is okay, then I prefer to go directly in place, but what I learned from René Chapeau and the other colleagues, Alberto Gil from Spain, Charbel Monayer from Limoges, France. If you want to confirm the proper preparation of the balloon, it's better to inflate it in cervical ICA in a more safer place. And if balloon properly prepared, then everything is okay. If it's not properly prepared, then the visibility of the balloon will be worse, and it may cause complication. You may rupture the artery. I have seen those complications, and one of my first use of the scepter balloon was related to those mispreparation. At that time I was user of Hyperglide, Hyperform, and I didn't expect that in the dead space so much force, and during the injection I couldn't see the balloon, and it was a Philips machine. It was just one screen active and not dual fluoro. In dual fluoro we can see the unsubtracted image also, but it was only subtracted image on roadmap, and balloon was inflated till 1 centimeter. And I realized the balloon inflation just at the time of the complication came. That's why it's very important for the beginners, and not only for the beginners, for the usual practice, it's alphabet, yes? If you are planning to do endovascular treatment, you should follow the rules. Yes, it was just one of the first cases of scepter in my country 12, 13 years ago. And nowadays we are trying to teach our colleagues, and not only in Kazakhstan, also through the YouTube channel, to prepare properly the balloon. And just after the link in Paris, we had a conversation with the Jivan Ishlak. He's from Istanbul, and he also mentions that on the next WLNC it should be focused on some of the cases how to properly prepare the balloon. And nowadays more and more people start to use double lumen balloon for the AV fistula, AVM treatment, and for any other reason. And I think those complications might happen in every place. Okay. The preparation of the Eclipse balloon double lumen is similar. It's preparing in a similar way. Okay, 37 left will be the working projection. Yes, and the beauty of the system, if this 3D image is one by one to the AP tube with the Philips, then it's possible to use it as a 3D roadmap. Okay. Yes, we didn't change the AP tube. It's still large focus defect. That's why. Okay. Now we have 3D roadmap. On a Siemens, on the biplane mode, it's possible to use both planes as a 3D roadmap, but on the Philips it's available only on AP and not available on the lateral. Okay. It's a little bit tortuous, and the navigation of the instrument could be little bit problematic. Oh no, it's going with no problem. Okay, no problem. Okay. Let's do more zoom. As the problem is, there is no 3D roadmap on the lateral plane, but it's available on AP. And now for the more visibility, you couldn't see the same on YouTube, but on the big screen we have a 3D roadmap. I hope Evgeny can place the 3D roadmap on YouTube. Okay. Yes, now we are going for one of the branches. It's a fusiform long M1 segment. Yes, it's possible to push a little bit more, and then we can straighten the Chikai black. We can push it like this, and then if you pull it back, then the segment is more straight, then less stress for the aneurysm. It's just moving free with no problem. The strategy in this case will be the placing the Leo baby stand. Okay, you can push a little bit more. It's not necessary, but for the stability maybe we need a little bit distal location. Okay. Yes, for this kind of navigation I prefer to use the headway tool, which is more softer, and for the scepter navigation we need a more distal wide location. Yes, the contrast part of the Chikai black is more softer, and the metal part is more stiffer. That's why we need a more metal part to navigate the device properly. Now we change the anatomy completely. I will ask Roland to put the Chikai black inside the gamma. Okay. Yes, and now the 3D roadmap is not no more actual till we replace, till we little bit release the tension in the scepter. Yes, everything is clear. No extravasation I've seen. Yes, and only problem, as I promised, we didn't check the contrast inside the balloon, but now with gentle injection I will show how to check the contrast inside the balloon. Okay, because of the hundreds of balloon annually used in the department, we usually do it automatically, but let's, for the educational purpose, I will show you the balloon contrast. And the very important point to see the contrast inside the balloon, to put the blank roadmap. It's very important. Трöst. Келесін сосын ойым салды, мен баллон көрсетші. Tröst. Okay, now I will place the gamma. As today we have a short 8 French sheaths from Teruma. The guiding is 8 French Klimber from Teruma. It's a coronary Judkins right guiding. It's very stiff and quite stable. Scepter C4 by 15, and now we are placing gamma DS. We order all gammas in the department DS. there are also gamma D. I think the difference between gamma D and gamma DS is just the softness of the distal part, and we order DS, which is, I think, softer. Yes, my assistant Rawan Aitili and the anesthesiology team, operating nurse is Zoya today. Okay, we'll have 3D roadmap for the navigation. Yes, it goes same direction. It's a shipping. As René Chapeau says, it's a shipping technique. Yes, it's a ship technique. Okay. Okay. Now let's on the blank roadmap. We call it blank roadmap. I will inflate the balloon. As you can see, balloon is properly prepared. It's fully contrast. There is no negative parts, interruption. It's a good preparation of the balloon. It's a 60% contrast. You can put a little bit more, then the deflation time might be longer. Okay. The gamma may stay at this point, but it's angulation part. That's why it might be a little bit unstable. Okay. Now we are inside the aneurysm. I will ask Roland to put the roadmap, previous angio. Алдындағы ангиография. Roadmap қойға сал алдындағы ангио. Вперед. Roadmap. Окей. Еще раз. Смарт маск қойға сал. Вперед. Вперед. Вперед. Вперед. Стоп. Вперед, вперед. Осло. Yes, smart mask. Yes, now the gamma inside the aneurysm, but I will leave my wire inside. And now we will start to deploy the... yes, I think it's better to leave the wire inside. Or maybe without wire. Let's see. Let's check once again. And we will redo the roadmap. Okay, everything is okay. The aneurysm is approximately 2 by 5. We will start with the 2 mm coil. Yeah? Okay. Спираль. Так. EKD6 complex soft. It will be Optima complex super soft. Complex soft, yes. And now we need to take a stent. High stent ashams. Just a second. Yes. We have 18 millimeter lengths baby stent, Leo baby, and also 2.5 by 20 Achero heel. This point I think very important because it's a neck of the aneurysm. It's entrance zone 2.9, and stent will be. We can place it as a half T stenting, just finish at this level, not to change the angulation. 2.9. We can take little baby. 2,5 мен 2-ні көрсетіп жіберсеңші. Аударып көрсетсең. Yes, 2.5. Мынаны бересің. We will place 2.5 by 18. It will be placed in a half T manner without going to the M1 segment. As the other possibility, we can place it in a C shape. We can place the proximal part to the distal M1. Okay. İtiriyor. Yes. Through the scepter, we will place a little baby 2.5 by 18. Yes, İtiriyor. 2.5 by 18, little baby will be placed through the scepter C, and then through the gamma we will place several coils inside the aneurysm. As for this kind of cases, I prefer to use 25 millimeter stent because of the wide neck and the small dome. Okay, let's see what we can do in this case. After the relaxing the scepter, everything will be changed in this place. Okay. You see the gamma starts moving. Okay, I will release it a little bit. Yes, now I think we can place it like this. A little bit too. Yes. With the Elvis Evo, usually after deploying the half of the stent, the remaining half is shrinking twice. It means that you deploying half and then 25% will be deployed. Okay, for this case we deployed it's more than half, I think. And usually the remaining part will shrink twice and then the stent will end at the M1 segment. Yes. Okay. Push. Iter in Kazakh language is push. Okay, let's go with the stent. And the other problem after deploying the stent, the aneurysm sizes should be corrected because it's not the true size of the remaining part. Everything is changed. Smooth mask. Also this. Okay. It's around the stent. Okay. Now I think we can fully deploy the stent. Yes. Now the stent is fully deployed. and it might be this stent still attached to the delivery wire because of the torker birsa. Torker. Because of the angulation, it might be still inside. It's okay, it's around the stent, but I will prefer to move a little bit more in the aneurysmal part. One coil is enough, I think. Huh? It looks like one coil is enough. Maybe one more small coil. We will see. Okay. Now coil is delivered. Okay. Yes, it's a Presidential National Hospital. The video support today Evgeny Grishayev. He's chief of the video KZ company, and we are doing the job together since 2017, since the time of first neurodic. Okay. Now stent is detached completely. Okay. The second manipulation, I will go with the GK black and push the stent to the upper branch. Trotter zaitam. Yes, the operating nurse is Zoya, the second nurse is Akhil, and the anesthesiology team. Anesthesiology Khuanch Dolatovich and the anesthesiology nurse. Yes. Okay. Yes, and interestingly, surprisingly, this patient under general anesthesia, which is not common to our patients in the department. Most of them are usually with the local. We try to operate under local anesthesia. Okay. Now we went with the scepter. I'll try to go with the scepter. Okay. Okay. Now I should collect my coils. Yes. Yes. Now there is some problem with the coil. Okay. Now it's better. Okay. Now coil is delivered inside the aneurysm, and let's inflate the balloon. Okay. We will try to go again inside the stent. Oh no, inside the aneurysm. Yes, the main point, we should take some wires of the stent to push it forward with the balloon. Sometimes it's possible, sometimes it's not. Okay. Yes, we inflated a little bit the balloon, and then the inflated balloon will push forward. Okay. Maybe this position is better for the stent. We'll see. Okay. The small part of the stent in the MCA. I think it's inside the aneurysm, no? No, outside of the aneurysm. Yes, the gamma is moving. It's not a problem, it's attached to the coil. So I can replace it. Okay. Let's deflate the balloon, and then we can do one more angio. It's not all the time very effective to do C-stenting, but we tried to do. Yes, we can place one more coil, eh? There is a place for one more coil. But the stent will work, and not all the time it's necessary. Mynzhylky. Yes, it looks like stent is fully opened. Böyle spiral. Yes, now the coil is detached. It was attached to the gamma. Okay. It's under the gamma, that's why no problem. Yes, because of the direction of the branch, the C-stenting is more logical. But this shape is also okay. Maybe it's not so necessary to do the circulation. It's outside. Yes. Okay, let's inflate in this place. Then we can inflate the struts of the stent. Okay. It's also possible to inflate under the blank roadmap, and then it's also possible to deflate under the blank roadmap. Yes, we should see the movement of the coil tip, and also the stent is not moving. That's why I think we went through the stent, and now we little bit enlarge the stent mesh, and everything should be okay. Yes, stent is opened, but it's not fully opposed to the proximal part, which is a little bit problematic. Yes, that's why I'm trying to pull the stent a little bit distally. That's a reason of manipulation inside the proximal stent. And sometimes we are able to push the stent. There is a branch. It's better to pull a little bit this stent to the upper branch. But changing the direction is usually very helpful. Yes. Okay, let's see. If the Jose Cohen is looking for the video, after the case I will do the comments as I promised him. Yes, last time I promised to Jose to do comments after every case. I'm just trying to convert the half-T stenting to C-stenting. It's not possible in every case, but I'm trying. Okay. It's not moving. Yes, we can leave it like this, no problem. The stent is opened. It's like a parallel channel in the artery. Yes, re-entry to the stent is a little bit painful. The stent is fully opened. Okay, let's try once more. One more time. It's inside the aneurysm. It's not going there. Let's inflate the balloon to confirm that everything is okay. Yes, now it's inflating and deflating. Okay. I think we can finish. The stent is opened. It's not as we expected, but it's not a C stenting. But stent is covered the coils and the part of the aneurysm is still filling, but the stent is also will work and it should be no problem. The stent is patent. Okay. It's not as open cell design, that's why the braided technology has its own characteristics. Huh? Okay. It's 19 minutes from the beginning. We can wait for another 10 minutes to confirm that everything is okay. Okay. It's the 45 degree. Yes, on the lateral view everything is okay. The stent is fully open. On the AP view it's the picture a little bit confusing because of this last loop of the coil, but it's not in the M1 segment, it's around the stent and everything is okay. Yes, the small part entrance to the branches looks like opened, but yes, we can follow and we can do second session if it's needed to go in parallel and dilate with the balloon and place another stent inside the stent if it's needed. Okay, let's see AP. Yeah, basement gepard. The last angio will be at 30. Now it's 20 minutes after the deployment of the stent. Because of all manipulations, we need to be sure that everything is okay. Because of the limit in the budget, today we have one more case, and tomorrow I should be in Kızıldağ city, which is more than 1,000 kilometers from Almaty. It's still in Kazakhstan, and we are planning 6-7 cases there, the complex ones, and after that I planned my consultations in Kızıldağ, and on Friday, Saturday we'll have consultations in Chimkent city, which is a little bit closer to Almaty, on the border with Uzbekistan, Tashkent. And then on Monday, we are planning several cases together with team of Medicover Uzbekistan, with Maksat Askarov. There are several cases in Tashkent, and then next Tuesday I will be in Almaty. Maybe we can do some cases next Tuesday in Almaty. Okay. As I said in the beginning to the Jose Cohen, Jose, this is especially for you. We navigated Chikai Black through this wide neck aneurysm and placed the scepter in the lower branch. It was a scepter C 4x15. 15 is my lovely length of the balloons. I prefer Hyperglide 415, Eclipse 615 and Scepter 415. It's inflating as a sausage and not bulging too much inside the aneurysm neck, comparing with the Scepter XC and the short length Eclipse 69, 67. Then we place the gamma inside the aneurysm. After placing the gamma, we start to deploy the, yes, it's a measurement. We start to deploy the level baby. The beginning was okay, but the end part, this part, because of this tight angulation, not fully opened as we expected. We tried to push it to this branch after the deployment, but it was impossible. And we left the stent at this level and placed one coil 2x8, which is Optima from Balt. This is the placement of the coil. We tried to push with the scepter the distal part of the stent. It was impossible. And after detachment of the coil, stent was attached to the gamma and a little bit outside of the aneurysm, but it's still at the aneurysm level. We changed the angulation, we did the angioplasty, everything is okay. We confirmed that everything is okay. If you see those two views, on lateral, the stent is fully opened and opposed. On AP, maybe it's not like this. Maybe it's not like this, and the stent looks like this. But there are an invisible part of the stent, and but I think it's not attached to this wall. There are some distance, but this stent is fully open. You can see the stent is fully open. Then we inflated inside the mesh of the stent, and we enlarged this part of the stent to prevent the thrombus formation. And this coil is inside the aneurysm. We changed the angulation. We confirm that the coil is at the aneurysmal part, and this part of the artery is patent. Everything is okay. And now, as usual, as a protocol, this was the last angio till now. Small part is filling, but with the stent and the coil, this part will be occluded on the follow-up. Usually follow-up MR in 3 months and the angiography in 1 year. We will see. It shouldn't cause any problem. There are places for one more coil, but I'm not sure we should treat the picture. For the aneurysm, this part is occluded. This part will be occluded with this stent, and this part stent is open. And now we should wait for another 4 minutes. In between, I asked Rowan to do expert CT. Okay, let's wait for the expert CT. Okay, dear colleagues, the expertise is ready. Some atherosclerosis, no problem. The MCA territory, everything is okay. The brain is clear. Let's see the coronal view. I think it's a distal part of the stent. I can see the mesh of the stent. Okay, let's see more closely. Because of the coil we couldn't see. Okay. Now it's time for the control angiography. Rowan, just over. Okay, let's wait for the last control. Okay, dear colleagues, the last control is ready. I hope it's the last control. The MCA territory is clear, the venous phase is clear, no delay. It's the first point. As a perfusion imaging, we are looking for the venous phase, no missing veins, every veins are in place. And now we can see the M1 segment, which is clear. Aneurysm is occluded, the stent is open, and everything is okay. Thank you for watching. See you in next 30 minutes. Next case is vertebral artery V1 and intercranial segment stenosis under local anesthesia. See you in 30 minutes. Thank you for watching.